is Manny Barbosa and welcome to my channel. So today we're going to be talking about Impella. So when you're getting a patient from cath lab, one thing that the ICU nurses nowadays is doing is caring for a patient with Impella. So the first requirements for you to be able to be more competent is to complete the Biomed online module, print out your certificate of completion and give it to your educator or your nurse manager. And in this video, I will add some of the roles and responsibilities that as an ICU nurse would do. So you have to remember that the cath lab nurses will be doing differently from the ICU nurses. So the cath lab will initiate the Impella, introducing or putting in the Impella machine or the device, and then we will continue the care in the ICU if a patient remains unstable. So in the past, then the patient with PCI, percutaneous coronary intervention, will get Impella for support, but they have to discontinue it, and then the patient will go to either step down and then go home from there. But we do have a more complex cases wherein the doctor would decide to keep it. So what do you do when you get this patient in the ICU? First, you need to understand that there are types of Impella, but what we're doing and what we're using nowadays is the 5.0, which delivers 5 liters per minute. And in the video, you can see how the Impella works, and please pay attention to the Biomed references or educational videos because we will follow the recommendation.
Impella system is placed percutaneously through the femoral artery using a monorail technique and a standard pigtail. It is advanced across the aortic valve and into the left ventricle. Impella pulls blood from the left ventricle and expels it into the aorta, actively unloading the left ventricle. This active unloading of the left ventricle increases end organ perfusion and protects the kidneys from acute injury. Impella is the only percutaneous heart pump providing hemodynamic support to enable heart recovery. Impella is indicated for protected PCI and cardiogenic shock in the setting of AMI and post-cardiotomy. Impella provides hemodynamic stability during angioplasty and stent placement by maintaining mean arterial pressure. By providing hemodynamic stability, Impella may allow for more complete revascularization in a single session, which has been shown to decrease the rate of major adverse cardiac and cerebrovascular events. A randomized controlled trial and additional studies have demonstrated a reduction in peri- and post-procedural adverse events. Impella promotes myocardial recovery by stabilizing hemodynamics, unloading the left ventricle, and perfusing the coronaries and end organs.
So the Impella mechanism of action, as we all know, it is the smallest left ventricular assistive device. The faster rotation, the higher the flow. And in the video, they give you an idea to keep your P performance level to either P8 or P9 for optimum cardiac output. Okay, so that's something that please pay attention if you're getting your patient. So the first thing I want you to understand is how do they make that decision if a patient can actually get Impella versus balloon pump, right? So if they're hemodynamically stable, they're normal, but they are higher risk of PCI, percutaneous coronary intervention. If it's a high risk, they put them on a support standby to see if if this patient going to deteriorate or decompensate. But take note, there are contraindication in using Impella. Number one is your left ventricle thrombus. Number two, if you have mechanical aortic valve. So you had surgery procedure before, they put a mechanical valve, so you cannot get Impella. If you have a severe aortic regurgitation, so it's not closing, then that's not good either. Or if you have ventricular septal defect or atrial septal defect, you can't get Impella, because once that machine or the device is inside the left ventricle, it starts sucking blood. If you have ventral septal defect, of course, you're sucking blood from the right ventricle, so now you're mixing oxygenated blood with unoxygenated blood, so it's not good, right? What about if you're abnormal but stable? So again, they will consider giving you or putting the Impella. If it's a high risk PCI, again, they're gonna go back to like what are the criteria for putting Impella again. If you're showing some signs of shock, left ventricular failure, definitely if it's a pre-shock, then you're gonna get balloon pump. But if you're gonna have this severe shock, then Impella is better because it gives you that cardiac output. And if it's a refractory shock, then of course we become, if your institution is putting an ECMO, then the patient will get a venous or arterial ECMO, VA ECMO. But if not, then that's something that they need to either transfer to a bigger medical center for higher acuity care. So again, as I've mentioned, what are the contraindications for Impella? If you met all this left ventricular thrombus, because you don't want that clot to get spread out and cause stroke, mechanical aortic valve, severe aortic regurgitation, ventricular septal defect or atrial septal defect, then there's no choice. I mean, they have to look at some feasibility, or is it okay to put balloon pump, or is it contraindicated, or things like that. But if you don't have any issues with that, then go ahead, they will put an Impella depending on your femoral access. Okay, so if you don't have a bigger femoral either vein, then what they're going to do, or femoral artery I should say, because it goes to the artery, then they would probably look for alternative access. And if it's feasible, then you get the Impella. But if it's not, then they will settle in for the balloon pump. So that's the reason why you see balloon pump or you see Impella. Again, it all depends on the preference of the cardiologist or cardiothoracic surgeon. I don't know which who's putting it in your hospital. Nevertheless, I want you to, just like what you normally do with your ICU patient, you look at them, assess them, level of consciousness. Are they awake? Are they following commands? Are they able to keep their affected legs straight? So those kind of things. And if they're not, then you ask whoever is giving you a report, why is the patient LOC? Is not, did you give him some sedation? Things like that. Do you like your hemodynamics, whatever you're seeing on the monitor? Is your mean arterial pressure adequate for you to be happy? So if not, then that's something that you might want to ask the, why is the blood pressure low? And if it's volume issue, then give volume, right? Albumin or normal saline. And then once everything is good, then you're ready to change the purge fluid. Then in the video provided by Abiomed, it is imperative that you follow that instruction and you do not highlight some of the things that they don't want you to be doing, especially like the hemostat, clamping it. You can't do that. Or if you have any question, again, I highly recommend for you to complete the module that the Abiomed website is providing, so that you get all this information. It is imperative that you follow those.
Impella controller. To begin the Change Purge Fluid Bag procedure, select the Purge menu soft button. Use the selector knob to scroll to Change Fluid Bag and press in on the selector knob. This procedure should be completed within 90 seconds. The supplies needed to complete this procedure include a bag of dextrose, 5% in water with heparin. Press Start to begin the procedure. A blue progress bar will appear while the automated Impella controller primes the system. Once completed, the AIC will automatically advance to the next screen. Replace the Purge fluid bag by unspiking the original fluid bag and spiking the new Purge fluid bag. Once completed, select Next. Enter the Purge fluid information. If the values need to be adjusted, press the Edit Soft button. If the default values are correct, select Confirm to verify these values. The AIC will move to the Prime Impella screen. If preferred, the Skip Prime button can be pressed to avoid priming the tubing with the new Purge fluid and complete the Change Purge fluid bag procedure. To flush the Purge fluid from the cassette, disconnect the yellow lure from the Impella catheter. Do not use a hemostat to disconnect the lure, as this could damage the Impella catheter. A blue progress bar will appear while the AIC primes the Purge tubing. Do not connect the yellow lure during this step. Once priming is complete, the AIC will automatically advance to the next screen. Connect the yellow lure on the Purge tubing to the yellow lure on the Impella catheter using a wet-to-wet connection. The Change Purge fluid procedure is now complete. Press Done to exit the Purge wizard.
So this is the hemodynamic effects of Impella, and also I would put a video here that came from a biomed that will guide you more in understanding. Again, guys, the goal is increasing oxygen supply to the myocardium, decreasing oxygen demands, right? At the same time, you're increasing cardiac output, optimizing your mean arterial pressure, and at the same time, that cardiac output power. It's imperative that you look at your screen all the time to see if you have a more than 0.6. I think the recommendation is more than 0.6%. The higher the number, the better. The lower the number, the higher mortality it is.
Hello, my name's Joe Kajewski. I'm one of the advanced Impella trainers with Abiomed. And today we're going to take a deeper dive looking into our AIC, or the automated Impella controller, to make sure that you understand everything that you're seeing on our placement screen. So this simulator is going to simulate what that automated Impella controller reflects while we have a patient on Impella support. So we're going to start by looking at the soft buttons. The soft buttons from the top to the bottom. The first button is our mute alarm button. This is going to be to silence any alarms that you may have. It is important to understand that there are 3 different colors of alarms, and those are in order of importance of red, yellow, and white. So the red alarm means that the pump is not functioning to support the patient. So this is going to be like your pump position wrong alarms. Your yellow alarm is going to mean that the pump is functioning, just not adequately supporting the patient. So this is going to be more like a suction alarm. You're still getting flow, it's just not at that ideal spot that you would have at that given P level. And then the white alarms are going to be more your FYI alarms. So this is usually if they're doing something in the background with the Purge solution. It might give you a message just saying, hey, I did this. So more just of an informational alarm. The next button down is our flow control button. It does exactly what it says. Anytime you want to control the amount of flow that we're giving that patient, you're going to go into the flow control button. We run the device at different P levels. As you adjust those P levels, that will be reflected in the lower corner where you'll see that flow adjustment. Display is going to be anytime you want to change what you're looking at on the screen. 99% of the time you will have it on the placement screen, which is going to give us our placement signal and our motor current. But you could also use this display button if you wanted to look at your infusion history, or if you wanted to show family the picture of where the Impella sits within the heart. Next, we're going to go to the Purge system button. So as you know, the Impella controller has an integrated IV pump that has D5 with 50 units per ml of heparin running through it. This protects our motor. There are going to be times when you're going to need to take an action on that Purge solution. You may need to change the bag. You may need to change the cassette. Anytime you want to go in and take an action on that Purge, you're going to go into Purge system. And then the last button is our menu button. Now this button you might not use as often, but it is going to allow you to look at maybe the alarm history. That would be one reason to go into that menu button. When we look at the bottom of our screen here, you will see that over at the far left-hand corner, it's going to give the additional amount of flow that we're giving the patient. Again, controlled by that flow control button or the P level that you're on. You'll notice that the larger number here is giving the average amount of flow at that given P level. So max flow is 3.8, min flows are going to be 3. So even though this is a continuous flow device, we still have the native heart working as well. So we will have a max flow and a min flow during the cardiac cycle. This is just the average amount of additional flow the Impella is giving. Our middle of our screen here is going to look at what's happening with that integrated IV pump. So this is going to tell us that purge flow, or the rate that that purge solution is going, as well as the purge pressure that's behind that purge flow. And then you'll see that on the far right hand of that common screen, we will have the additional metrics. So that's going to be inputting the cardiac output, and then the AIC will automatically calculate the CPO to allow for trending of that CPO. As we look at the waveforms that we see on the placement screen, you'll notice that we have a green waveform, which is our motor current. The motor current is going to help with identifying positioning of our device. So what is motor current? Motor current is essentially looking at the amount of energy and flow through the cannula. So when the valve is open, I have more energy, more flow, which will be reflective of the peak on our motor current. When the valve is closed, I'll have a higher gradient, which will be less energy, less flow. So it'll be reflective of the valley on our motor current. So when the device is in the correct position, we will have a nice pulsatile motor current. When the device is malpositioned or maybe drifts in or out, then it would be reflective of a flat motor current because the aortic valve is no longer creating that pressure gradient across the cannula. You'll also notice that we have a red waveform, or our placement signal waveform. So this is going to give us two different waveforms. It's going to give us the AO waveform, and it's going to give us an LV waveform. Now the AO waveform is simply from that optical sensor. The optical sensor is located where the cannula and the outflow meet. So wherever that sensor is the waveform that we will get from the red waveform. The LV waveform is going to be essentially the waveform derived from using that optical sensor and the motor current. So this is going to be an estimated LV waveform. So this was a brief overview of the automated Impella controller to help you better understand the waveforms that you're looking at and to be able to better navigate the controller when you have a patient on support. Hello, my name is Jo Kajewski, and I'm one of the advanced Impella trainers with Abiomed. And today we're going to discuss the hemodynamic benefits and physiology of the Impella device using a bedside monitor, which we use for educational purposes to simulate the hemodynamic benefits, or what happens to a patient when they're on support, what you would see on a bedside monitor, pre and post support. When we look at this patient prior to turning on the Impella device, you can see that the blood pressure is 83/53 with a MAP of 62. So definitely not that target MAP that we would be hoping for. We would question end organ perfusion at this time. SVO2 is 57. My cardiac output is only 3.9, so that is not within that 4 to 7 normal range. Cardiac index is only 2. My wedge is 27. So why do I care so much what my wedge is? This is why it's important to always have a swan in these patients. The wedge is actually looking at the filling pressure for the LV. So in the absence of mitral valve disease, you would hope that the wedge and the LV EDP would be in the similar range. So this is the only way that we can see what's going on with that pressure and volume within the left ventricle. As we continue down, you can see that my CPO, or my cardiac power output, is 0.53. So for those of you who are not familiar with cardiac power output, it has been shown to be the #1 indicator of in-hospital mortality. Anything 0.53 and below, you're going to have around a 50% mortality rate. So where we get the number 0.6 from is we want to improve that mortality rate. So we're going to trend that CPO to help improve our outcomes. So 0.6 is that minimum CPO that you would want while you have a patient on support. So what happens when we turn the Impella device on? When we look at our hemodynamics post-Impella support, we can see that our blood pressure went from 83/53 to 88/72 with a MAP of 76. So our systolic blood pressure really didn't jump that much, but our MAP jumped up from 62 to 76. So why is this important to know? Whenever you have a continuous flow device that's directly unloading the ventricle, it's going to raise that diastolic pressure. So we always want to titrate everything to MAPS versus systolic because we're resting the ventricle. So our systolic blood pressure may not jump up that much, but because we're flowing during diastole, we're going to raise the diastolic pressure, hence raising the MAP. As we continue down, you'll see that our SVO2 went from 57 to 64. Because we're unloading the left ventricle, we're relaxing that muscle. The myocardium is not consuming as much oxygen, so that is going to in turn raise our SVO2. As we continue down, our cardiac output went from 3.9 up to 4.8. So if you're looking at that, you may say, this isn't giving my patient a whole lot more support. It's only giving about a liter more. However, if we break it down for what the native cardiac output is doing, before the native heart had to give that full 3.9. Now it is only having to give 1.5 because our Impella device is actually giving 3.3 liters of additional support. So that gives you a good idea of how much the heart's able to rest when you have a patient on a mechanical support device that directly unloads the left ventricle continuously. As we continue to go down, you'll see that my LV-EDP, my wedge pressures, went from 27 down to 19. Why is that important to know? Because that wedge pressure is the filling pressure for the left ventricle. It's going to give us an idea of what's happening in that left ventricle. So if I can decrease or unload the volume, I'm then in turn going to decrease the pressure and the wall tension. And then my CPO, which we already talked about being the number one indicator of in-hospital mortality, we wanted that number to be above 0.6. I actually went from 0.53 all the way to 0.81. So you can see that dramatic change in the amount of energy the heart has to continue that cardiac output and that MAP. So this is a brief overview of the hemodynamic benefits and physiology using Harvey app in the background and converting that to what you guys see on a day-to-day basis looking at your bedside monitors.
So one thing that I want you to pay attention here before you watch the video is this white. If you see this white, this is pretty much your left ventricles, okay? And then the red is your aortic pressure in there. So you should see the red and either white or gray. It's just gonna tell you that this is your pressure into the aorta, and this is the left ventricle pressure, okay, 141/7. And over here, the green, you should see a pulsation like this because this is telling us that the motor is, you have two different sides, right? The inside the ventricle and the outside the ventricle or outside the aorta. If it becomes flat, then that means they are in the same chamber or same location. So this is something that I want you guys to always look at. This is the cardiac output, okay? So you have to remember that your patients still have their own cardiac output. You're just providing them an additional flow. So therefore, your cardiac power output, it's 1.2, which is good, right? So I told you above 0.6 is what they want. All right. If you see this, so the alarm will then become red. Any kind of red alarm, you really need to check your patient and check your pump or your Impella. It's telling you that the Impella was pulled back into the aorta because look what happened to your motor. your motor became flat, right? However, it's telling you here that it's positioned in the aorta. So what do you want to do? You reduce the P level to P2. But before you do this, you have to make sure you call your doctor right away and say, hey doc, whoever is in the unit, if you're a night shift, then you probably will page somebody. If you have a doctor there, grab that doctor right away. And follow the instructions here. You reposition by using imaging, either echo or x-ray. You return to your prepared P level once you confirm that you fix a problem, then you go back to P8, right? So again guys, you go all the way to P2, P level to P2, while you're figuring it out what's causing this current motor to go flat. All right. So what about if your impella moved into the ventricle? So again, what you see here is this ventricular, okay, ventricular rhythm here, and it's telling you this number here. Okay, again, the console or the machine will tell you again that it is in the ventricle. So you just have to really read what's in front of you, what is the machine is telling you, and that's how you're gonna work with this Impella machine. Remember guys, I told you that your cardiac output, look, it's missing in here, and your cardiac power, it's gone because you don't have anything. It's all the catheter just migrated inside. So what do? You reduce your P level to P2 again. Okay, call the doctor first, and then you do this thing. We highly recommend to do that. You just don't fix it yourself, because we are registered nurses. We don't have any license. I mean, you have to take care of your license. We're not practicing medicine. We still need the help of the doctor, right? So you reduce the P level as instructed. When ready to reposition, you press the menu soft key, then you select the repositioning guide. So that's something that you need to help the doctor. All right. So again guys, I highly recommend it to follow what the video recommends. So what would be your nursing responsibilities when it's time to do a CPR? First, you need to change the performance level to P2. It's automatic, P2. And you need to defibrillate your patient if you think like you have ventricular fibrillation or pulseless ventricular tachycardia, right? Because those are the only two shockable rhythm. Compression. Be very careful. I know you have a good intention to do your CPR, you lose the pulse, blood pressure's dropping, and you jump in right away. But you have to remember, you're a patient with Impella. So you need to consult with the doctor first. If the doctor said go ahead and do compression, you go ahead and do your compression. But because when you do compression, it may dislodge the cannulation, and it would cause bleeding, or you will lose that support, right? So be very careful. If you got the patient back, so survive the resuscitation, then you verify the pulsation of the device again with echocardiogram. So make sure you check it again, the placement, and then you resume the P level as prescribed. If you stop from P8, then go back to P8, performance level P8. And then make sure that you respond to the device alarm, such as the red alarm. It's probably more of hemodynamic support, pressure, things like that. The yellow alarm, it's probably suctioning issue, dry issue, things like that. Your patient's probably dry, that they don't have enough cardiac output, so you need to, volume. Or it's just an FYI, which is a white alarm, okay? And of course, you notify the doctor if you need assistance, then they need to be at the bedside with you. Then when you're weaning and removing the catheter, Impella catheter, again, you follow what your institution protocol is. So weaning process is we do it by gradual weaning, such as level P. The P level should be reduced by two performance level every 3 hours. So if you are on P8, then you go down by 2, so you go to P6 every 3 hours, and then you remain at P2. Why? Because you need to observe the patient. If he is tolerating it well, look at your map, your mean arterial pressure. Do you have enough mean arterial pressure? Is your patient hemodynamically stable or not? Then you call the doctor, okay? And then that's what we call assess the patient for response to P2. And then when you are ready to remove the Impella device, again, it all depends on who's removing it. Is it your PA, or is it your NP, or is it you? So make sure that you check that with the hospital policy. All right. And if you have any question, let me know. You can actually leave a comment in here. If you work in my hospital, shoot me an email and I will answer any questions. All right. Well, thank you so much for listening. And my goal is to empower you so that you know how to take care of a patient with Impella. Thank you.